Thank you. Thank you, Professor Jarif, for your comprehensive presentation. Now it's our pleasure to present Professor Shalini Jaggi, the Director of Life Care Diabetes Center in the New Delhi. She is a fellow of the Royal College of Physicians and serves on various national and international diabetes research and advice. Welcome, Professor Shalini Jaggi.
Hello everyone, very warm greetings from India. It's such a proud privilege, honor to be part of this very elite 20th International Symposium in Diabetes by AASD. And my heartfelt thanks and gratitude to Professor Inas Shaltout for having me here. I'm sorry I'm not able to travel to Cairo because of some personal commitments this time. So last time we had a great meeting at Cairo when we were all there physically. This time I'm happy. I'm still part of the meeting, even if it is virtual. So my greetings to Professor Shaltout, Dr. Mohammed Hasnan, Professor Amr, Professor Orabi, and the entire organizing team of AASD. My heartiest congratulations for yet another milestone academic feast. And I'm sure we're all going to end up learning a lot more and interacting, even if I'm joining virtually. So once again, my gratitude and heartiest congratulations to Inas ma'am and her entire team at AASD. And of course, happy to be partnering with you. So moving on to my topic for today. Well, this is a topic which is very, very close to my heart. Let me just share my screen. So in the next few minutes, I am going to talk about a very important topic, gestational diabetes, and how it is today probably the key to preventing NCDs. Well, we all know hyperglycemia in pregnancy is increasing. And if you look at the prevalence of HIP in the IDF clearly tells us that all across all different regions, it's going up. And Southeast Asia actually takes the lead. 1 in 4 live births in the IDF Southeast Asian region are affected by hyperglycemia in pregnancy. And more than 80% of this is gestational diabetes, which is essentially diabetes that develops during pregnancy. So the mother is not really diabetic earlier. And eventually, because of the diabetogenic stress of the hormones and insulin resistance, this is a transient condition that develops in pregnancy. But why we need to take it seriously is because of the important concern. We now know that GDM represents detection of chronic beta cell dysfunction, and we know today that it is maybe a stage in the evolution of type 2 diabetes. Why I am saying that is because in the current pregnancy, once the mother develops GDM, not only are there increased risk of complications both for the mother and the offspring in terms of maybe preeclampsia, induction of labor, increased risk of cesarean sections, operative deliveries, complications in labor, and all those, even for the baby, for the offspring. If it is diagnosed very early, if it develops early in pregnancy, not only is there an increased risk of congenital anomalies, but eventually the neonatal complications, the child becomes macrosomic, there's prematurity, there's risk of respiratory distress, metabolic complications, so on and so forth. But the story does not end here. A mother who develops GDM in one pregnancy is not only at an increased risk of developing GDM in a subsequent pregnancy, but also eventually progressing to type 2 diabetes. And her offspring, who was exposed in utero to hyperglycemia in pregnancy, again, if this child grows up to be obese, develops metabolic syndrome, and is again at a higher risk of developing diabetes. So basically, the lifetime risk of type 2 diabetes in a woman with gestational diabetes goes up, not only immediately post this pregnancy, but eventually now data shows that 50% of women with GDM develop IGT within 5 to 10 years of pregnancy. They have a tenfold increased risk of developing diabetes compared to women who do not develop GDM in their pregnancy. And this risk keeps increasing linearly throughout her lifetime. So 20% risk 10 years post GDM, 30% 20 years post GDM, and so on and so forth. What is also important is that the women with GDM are at a high risk of cardiovascular disease. So basically, it is not only diabetes, metabolic syndrome, but also an increased predisposition to CVD, which again puts them at a very high risk of morbidity and mortality. And therefore, we need to be very, very aware of this entity. GDM impacts two lives. So basically, the high risk of maternal and perinatal morbidity and mortality is something we really need to be sensitive to, because diagnosing GDM not only identifies this woman as having a high risk of future diabetes and associated metabolic problems, but her offspring also can in the future develop all these metabolic complications, including diabetes. And therefore, GDM offers us an opportunity for primary prevention of NCDs and cardiometabolic disorders. You may ask how? Well, in the next few minutes, I am going to show you a number of different reasons why GDM is linked to future NCDs, and therefore, if we are able to pick up GDM early, if we are able to manage it well, so much so that the child is not exposed to hyperglycemia in pregnancy at all, maybe we can put a stop to this pandemic of NCDs. Well, the evidence linking GDM to future metabolic disease has been seen even in ancient Indian texts long back, almost 180 to 300 BC, where clearly the scientists in those ancient Indian times, in this text called Garbha Upanishad, which is thousands of years old, were able to actually pin down and say that an unborn child in the womb of his mother is already born with his destiny in terms of his lifespan, his activities, his acquisition of wealth and knowledge, and time of death, probably pointing to future NCDs as well. And this concept in modern times was again revived by this eminent scientist, Dr. David Barker, through his fetal and infant origins of adult disease hypothesis, where he conceptualized that the body's susceptibility to lifestyle disease was programmed intrauterine. So what exactly is this hypothesis? This clearly says that the susceptibility to developing cardiovascular disease, diabetes, insulin resistance syndrome is all programmed in utero. So basically, an exposure in the critical period in development of the child may influence later metabolic or physiological functions of this child in adult life. So clearly, an adverse environment in fetal life as well as early childhood eventually increases the risk of all these NCDs in the child who is exposed to this in utero in its adult life. So basically, what this says is the genetics are loading the gun. So basically, an adverse intrauterine environment, the child is already born with that kind of a genetic predisposition because of the epigenetic changes that may occur eventually when the child gets an adverse postnatal environment. Intrauterine programming or gestational programming is a term which actually tells you how stimuli such as hyperglycemia or stresses occur at a critical or sensitive period of fetal development, eventually causing a permanent change in the structure, physiology, and metabolism of this child, which predisposes this child to future diseases, NCDs, in adult life, the famous fetal origin of adult disease hypothesis by David Barker. So basically what we are talking about is when there is maternal glucose concentration which is exceeding what it should be normally, what happens is there's increased glucose sensing that occurs by fetal pancreas, and now we have evidence to show that the beta cells become capable of secreting insulin as early as 10 to 11 weeks of gestation. So if the mother gets hyperglycemic, this glucose crosses the placenta, and once the fetus's pancreas is able to sense this increased glucose, it again starts secreting insulin. So the insulin secretion by the fetal pancreas eventually results in insulin-mediated growth, influencing the birth weight of the infant. And that is why we talk about macrosomic babies born to mothers where glucose levels are not controlled. So the famous Pedersen hypothesis actually talked about glucose crossing the placenta when there is a situation of maternal hyperglycemia, producing a state of carbohydrate surplus in the fetus. So there is hyperinsulinemia in the fetus, which stimulates protein, lipid, and glycogen synthesis. And eventually, there is macrosomia, organomegaly, and all these complications, so on and so forth, that are associated with gestational diabetes. Now, Norbert Frankel actually went a step further and said it is not only the carbohydrates, but the overall nutrient excess, which may actually have a teratogenic effect in terms of causing all these critical problems. So therefore, he talked of the influence of maternal fuels during pregnancy as a basis for long-range anatomic and functional changes in the fetus. So basically what he says was a surplus of not only carbohydrates, but also protein and fat. So a situation of maternal overnutrition eventually crosses the placenta, leading to fetal hyperinsulinemia. So not only is this child born with an increased risk of neonatal hypoglycemia because of the hyperinsulinemia in utero, but eventually this child is also macrosomic. And once this child starts growing up, becomes obese, it is again at an increased risk of developing not only metabolic syndrome, but eventually having IGT, type 2 diabetes, and even cardiovascular disease. So the entire gamut of NCDs because of that intrauterine exposure that occurred. And therefore, GDM becomes very important. So putting everything together, if the mother has diabetes in pregnancy or hyperglycemia in pregnancy, not only is this hyperinsulinemia, not only is this hyperglycemia in the mother leading to hyperinsulinemia in the fetus, the fetus becomes macrosomic. Eventually, the neonate is born with hypoglycemia or all the other complications that I talked of. Now, here we again need to pause and see. Now, if this child who was exposed to intrauterine hyperglycemia happens to be a male child, of course, this child becomes obese later on because of adverse environmental effects and the epigenetic changes that have happened, develops IGT and gets diabetes, leading to a vicious cycle of diabetes, begetting diabetes. But what happens if this child is a female? The cycle becomes round and round and round. Why? Because now this female child, when this child becomes obese, she gets married, she gets pregnant, she develops gestational diabetes, and again passes on the tendency to develop NCDs to her child. So if it is a female who is exposed to intrauterine hyperglycemia, the vicious cycle continues because once she gets pregnant, she is again developing GDM. And then eventually she not only progresses to type 2 diabetes, but the child that she is carrying again gets predisposed to this intrauterine milieu of hyperglycemia, hyperinsulinemia, eventually leading to all these complications on and on and on. So what are the implications? A woman with a history of GDM is not only at an increased risk of future diabetes, predominantly type 2 diabetes, but so is her child. Therefore, we know that transgenerational transmission occurs. So, NCDs adversely impact maternal health, and poor maternal health increases the risk of NCDs. So, the cycle goes on and on. Like I said, maternal overnutrition, because if the mother is obese or if she's gaining excess gestational weight, eventually there is a milieu of intrauterine overnutrition. So the fetus that is developing is exposed to these adverse stimuli, leading to epigenetic changes in the genes of this fetus. The child is born with an altered physiology because of these epigenetic changes that occur. So the child becomes more insulin resistant, already develops some amount of beta cell dysfunction. Once the child becomes obese, there is an increased risk of not only obesity, but also diabetes and CVD in the offspring. What I talked of, the intergenerational effects and the long-term NCD risk because of maternal diabetes or gestational diabetes. The other end of the spectrum, maternal undernutrition, which is again very common in our countries, especially Southeast Asian countries. So if the mother is undernourished, their nutrient demand is much more than the placental supply. So the fetus is exposed to a milieu of fetal undernutrition. There's hypoxemia, there are altered metabolic changes, there are endocrine changes. Eventually, there is fetal programming that again goes adverse. So there are structural changes within organs, poor childhood growth, metabolic and endocrine dysfunction with which this child is born. So a child with intrauterine growth restriction again has an abnormal programming, a developmental programming, which is altering the glucose and insulin metabolism, the adaptations to adverse intrauterine conditions leading to an effect on the endocrine axis, on the periphery, on the muscles, liver, fat, cardiovascular system, brain, eventually predisposing this child to an increased adult risk for diabetes, cardiovascular disease, and obesity. So the link between maternal health and NCD burden is two ways. On the one side, you have maternal undernutrition, the Barker's hypothesis, wherein a child who's born small for gestational age eventually undergoes catch-up growth, or maternal overnutrition on the other end in terms of gestational diabetes or maternal diabetes, excess weight gain in pregnancy, leading to a macrosomic baby, the Pedersen hypothesis that I explained. Both of these predict the development of IGT, type 2 diabetes, and hypertension. And therefore, birth weight of the fetus is an important predictor of type 2 diabetes because the graph is all U-shaped. So on the one side, you have undernutrition. On the other side, you have overnutrition, both of which eventually put the child on a trajectory for NCDs. Now, this is the developmental origins of health and disease hypothesis, the famous DOHAD hypothesis, which actually again kind of reinforces this theory, telling how the early life conditioning again has an impact in terms of epigenetic modifications. There is histone modification. We now know there's DNA methylation, non-coding RNA mediated regulation. Of all these modifications, if they persist later in life, these condition the offspring to develop metabolic disorders such as obesity, type 2 diabetes, and cardiovascular disease. So the early life conditioning with all these epigenetic modifications, eventually the infant again has an increased risk of becoming obese, developing metabolic syndrome, becoming pre-diabetic, and eventually landing up with type 2 diabetes. So the cycle continues. Now, intrauterine exposure to hyperglycemia, to hyperinsulinemia, to inflammation, oxidative stress creates a very adverse intrauterine milieu for the child who's growing. And this is associated not only with what I told, the anatomical malformations or the congenital malformations, but we now have emerging evidence that there's hypothalamic dysfunction, there's increased risk of obesity, and now we have data which says that GDM may be associated to behavioral as well as neurophysiological defects in the offspring that may manifest at childhood, adulthood, or old age. So it is not only all these, but anxiety, neurocognitive development, maybe they are also linked to an adverse intrauterine environment. Because what happens is GDM creates a kind of a milieu of sterile inflammation in the body. So basically, there is dysregulation in the expression and activity of all these signaling pathways in the placenta, in the adipose tissue, in the skeletal muscle. All of these lead to an altered function of these tissues. So there's enhanced inflammation, there's placental dysfunction, there's an environment of endothelial dysfunction and insulin resistance, which predisposes this offspring not only to macrosomia, visceral obesity in short term, but long-term risk of obesity, metabolic syndrome, and diabetes. So friends, GDM plays a very crucial role in increasing the prevalence of diabetes and obesity. And therefore, we now know GDM is actually the fertile soil, the origin of cardiometabolic diseases. So a suboptimal in utero environment, as you can see, has an impact on all the different organ systems. You can see liver, adipose tissue, immune system, the appetite, cognitive behavior, placenta, the kidneys, the pancreatic beta cell. All the organs are touched by a suboptimal intrauterine environment. Now we know the link between pregnancy and lung health in the offspring. So the developmental origins of respiratory disease. So, if a child is exposed to either pre-GDM, pre-gestational type 1 or type 2 diabetes, which may result in congenital morphological abnormalities, but also gestational diabetes can produce functional defects and mechanisms in the developing respiratory tract of the child. So the neonate may not only be born with all those newborn respiratory conditions, but eventually the risk of COPDs, wheezing, asthma may also have its origin in intrauterine exposure to hyperglycemia. And this is again something that we really need to be very well aware of. So friends, GDM plays a crucial role in increasing the prevalence of diabetes and obesity. So it is very, very important that we have a universal screening of GDM and prompt management of all pregnant women for glucose intolerance very early in pregnancy and then every trimester, so that you can pick it up as it occurs and manage it well. It has to be a public health priority if we really want to, stop this NCD pandemic. This is a very important slide which talks how if you can, pick up GDM very early on and intervene either with MNT or insulin. And you can actually, if you can have a newborn who's born appropriate for gestational age, so neither small for gestational age nor large for gestational age, maybe this could be the first step in preventing obesity and IGT in the offspring. So when we talk about prevention of diabetes, the preventive measures for type 2 diabetes actually should start intrauterine. And that is where you need to stop this exposure to hyperglycemia when the child is not even born, and then continue this throughout life from early childhood, inculcate good eating habits, see that the child does not become obese or sedentary, so that we can actually put an end to this pandemic of diabetes and NCDs. So GDM offers an important opportunity for the development, testing, and implementation of clinical strategies for preventing diabetes as well. And like I said, both these spectrums, the maternal health impacting the NCD burden, fetal programming, IUGR, macrosomia, both of them have a role to play in predicting development of diabetes, IGT, hypertension, and the solution to this entire cycle is having a child who is not exposed to adverse intrauterine environment, not exposed to hyperglycemia in pregnancy, a child who is born with an optimal birth weight of between 3 to 3.5 kilograms, so that this child does not grow up to be obese, does not get metabolic syndrome, and does not eventually end up with pre-diabetes, diabetes, cardiovascular disease, and all the associated diseases. Now, this is again a very important aspect. I talked about how a female child who is born with this predisposition, when she gets pregnant, gets GDM, and eventually the cycle continues. So basically, maybe the key to diabetes prevention lies in the female gender, because I told you how low birth weight or large for gestational age birth weight eventually in adult life predispose to an increased risk for obesity, diabetes, hypertension, and CVD. And therefore, the intergenerational transfer of risk occurs from a female to her fetus, and this fetus again becomes pre-diabetic. And if this fetus is a female fetus, she goes up to be a female, gets pregnant, and passes it on. So maybe diabetes begetting diabetes, we can actually stop the cycle by focusing on maternal health, which is a very crucial link to the NCD pandemic. So friends, the goal of early screening and managing GDM is not only to improve perinatal outcome, but also to prevent the long-term maternal and fetal effects. If glycemic control can be maximized to an extent that the fetus no longer recognizes that the mother has diabetes, that is the level of diabetes control that we need in pregnancy. Then the treatment of mother during pregnancy may become the first step in preventing obesity and diabetes in the offspring, the NCD prevention that I'm talking of. So let me end by saying that GDM offers us a window of opportunity to provide maternal care services to reduce the traditional maternal and perinatal morbidity and mortality indicators, to address the intergenerational prevention of NCDs such as diabetes, hypertension, cardiovascular disease, and stroke. So to conclude, we as clinicians are therefore afforded this very rare opportunity to actually alter the natural course of disease and change the future health of women and their offspring today. So friends, GDM offers us a window of opportunity. It is actually the key to preventing NCDs. And in the words of Professor Seshia, who happens to be the father of GDM in India, to achieve a diabetes-free generation, we need to focus on the fetus for the future. So if there is a mother who develops GDM, not only do we need to sensitize her to losing weight and lead a healthy life in the future, post-delivery, so that she can prevent future development of diabetes, but we also need to focus on the fetus and ensure this fetus does not really grow up to be obese and gets diabetes, and therefore intrauterine health again becomes very, very important. So I think with that, let me stop sharing my slides, and I'm open to any questions, comments, or discussion that we can have. Thank you so much for your patient listening.
دكتور شاليني دلوقتي لو في اي questions ولا no questions.
Thank you, Professor, for your elegant talk. I want to conclude actually this session about diabetes in pregnancy. Professor Noha Gaber talk about cases or case presentation before pregnancy and how can we diagnose and assess our patients before pregnancy and then during pregnancy and after labor and also during lactation. It's very important. Thank you, Professor Noha. My question to Professor Rajiv. You talk, Professor, about treatment with oral hypoglycemic and many guidelines about this or researches. I want to listen to your clinical practice in your clinic or practice about use metformin or other sulfonylurea oral hypoglycemic treatment during pregnancy, first trimester, second trimester, or third trimester. Please, yes.
Thanks a lot for this question. I very clearly said in my presentation that insulin remains a growth factor. Every patient who comes with hyperglycemia in pregnancy, maybe in first trimester, second or third trimester, we give them the option of is found to be totally safe. Only concern with metformin, as I said, is that there could be little increase in prematurity and there could be small for date gestational offsprings born out of a mother if mother is on metformin, especially high doses like 1.5 or 2 grams. But the advantages are weight gain with metformin is very, very less. And still, in spite of full doses of metformin, 1/3 of the females will require insulin in addition to metformin to get a very tight glycemic control.
Thank you. My question to Professor Shalini, I want to know also the prevention.
Sorry, prevention of
Yes, ما هو قال yes, mom.
That is very important. That is why today we are promoting the concept of preconception screening. You know, for any woman in the reproductive age group, if she is at a high risk of developing GDM,
somebody who is already overweight or obese, somebody whose age is, more than 25 years, somebody who has a history of PCOS, or even a woman who's already had a bad OBS history, somebody who has a strong family history of diabetes. These are the typical women who are at a high risk of developing GDM once they get pregnant. So it is important to identify these women right in the beginning, so that even pre-conception we can talk to them about weight loss, we can talk to them about stabilizing all these risk factors. And then the concept of early screening, just as they get pregnant, the first test should be done when they report to the antenatal clinic for the first time when they've just diagnosed pregnancy, so that there itself you can at least rule out any overt diabetes or pre-diabetes. And then if she's negative, screening again in the second trimester and the third trimester for GDM is very important, because she's already high risk. So eventually in the second or the third trimester, chances are that there will be development of dysglycemia. And that is where, if we are able to pick her up early, counseling her on MNT, counseling her on continuing her lifestyle changes in terms of small frequent meals, in terms of exercising regularly unless until there is a contraindication. These are very important. There were some papers on using metformin to prevent GDM in women with PCOS or obesity, but most of the studies, half of the studies have shown that maybe yes, women with PCOS, you can probably delay the onset of GDM, but there were some more studies which showed that it did not really help. So I think metformin is something that may be used in PCOS pregnancies, but then the word is not yet out on whether we can actually prevent GDM by using metformin in these kind of ladies. So I think it's important to have an early screening to sensitize these women before pregnancy. And if we are able to pick up GDM, offer them the choice of MNT and lifestyle, and still if the glucose levels are not on target, insulin can be offered if the degree of dysglycemia is very high. Otherwise, if she's already in the second or third trimester, a choice of metformin can be given to her, because metformin relatively is safe. The only contraindications to metformin, like Dr. Chawla said, if she's already developing IUGR, if there is a risk of prematurity, if she's got preeclampsia, hypertension, the fetal growth is less, if the amniotic fluid is less, so those placental insufficiency, all these are contraindications to metformin in pregnancy. Otherwise, if these contraindications are not present, the lady is obese. In those kind of ladies, towards the end of this pregnancy, especially if the degree of dysglycemia is less, metformin may be offered. Otherwise, insulin remains the drug of choice in pregnancy.
Thank you, Professor Shalini.
بس عايزه اقول كلمه في استخدام الميتفورمين في البريجنانسي. الجولد ستاندرد عندنا الانسولين. اللونج تيرم ستاديز على استخدام الميتفورمين في البريجنانسي دي لسه ما حدش حطها ريكومنديشن، وبالتالي احنا في سيرتن سيتويشن خاصه جدا في استخدام الميتفورمين في البريجنانت، ومفيش هتعرض عليها ان هي الانسولين والميتفورمين وتقول لها هي سلامه البيبي او الفيتس عندها اهم من اي حاجه ثانيه. فلغايه دلوقتي الجولد ستاندرد هو الانسولين. دكتوره نهى دكتوره نهى في كويشن. GDM from
تمام. يعني هو جيستيشنال دايابيتس اهم حاجه الايرلي سكريننج والدايجنوزس، والكي بوينت ان اغلبيه الناس بتفتكر ان الجيستيشنال دايابيتس لازم على طول تاخد علاج. هو اب تو في الليترشر 65 ل 80% من الحالات ممكن لايف ستايل بس يظبط من غير ما تحتاج لا ادويه ولا انسولين ولا حاجه خالص. بس في مين بقى؟ ما انا جاي لحضرتك في مين، يعني مين اللي هدي فرصه لللايف ستايل، ومين اللي اي ويل ستارت ميتفورمين على طول في قصدي انسولين على طول في البيشنت دي. لو واحده جايه بآلة الالترا ساوند مع الدكتور النساء لاقي فيه مثلا ماكروسوميا او بوليهيدرومنز او فيه مشكله، يبقى ده مش هستنى لايف ستايل، لازم على طول هبدا بانسولين. لو جايه بقرايات عاليه ارقام ميتينات وارقام مبالغ فيها مش جاست لايت انكريز، يبقى دي مش هستنى برضو لايف ستايل، ممكن ابدا على طول الانسولين. او لو البيشنت دي مش ويلنج انها تعمل لايف ستايل وخلاص انا ضبط اكلي اوريدي ومع ذلك الارقام عاليه، ايه بقى اللي هيتعمل في اللايف ستايل؟ يعني نمبر 1 طريقه الايه التغذيه بتاعتها regarding انها تقلل الكربوهيدرات انتيك شويه في الميلز، ومش هنعمل حاجات ويرد، يعني مش هنعمل بقى لا كيتو دايت، ما ينفعش طبعا مع البريجنسي، ولا انترميتد فاستنج بساعات طويله، ده ما ينفعش. من الحاجات السكسسفول جدا انها تقلل الكربوهيدرات سبيشالي الصبح، يعني وجبه الصبح يبقى عندهم انسولين ريزيستنس، فنحاول لو هتاخد كربوهيدرات في وجبه الصبح ما تبقاش بدري، يعني الصبح تفطر بروتينز مينلي، ممكن حاجات فيها فايبرز، وتخلي الكربوهيدرات انتيك يبقى ليتر اون شويه اثناء اليوم، ما تبداش بيه اول اليوم. وبدل ما تاخد لارج 3 بيج ميلز، لا دي تاخد فريكوينت ميلز 7 ل 8 مثلا ميلز على مدار اليوم، وده هيخلي الجلايسيميك بروفايل بتاعها مور لس يبقى كويس. الحاجه الثانيه مهمه انها تتحرك، لو ما فيش طبعا اي ريستريكشنز من الدكتور الطبيب النساء بتاعها، انها ممكن تمشي او تتحرك. الاكسرسايز مهم، بيحسن السنسيتيفيتي الانسولين سنسيتيفيتي، وبيساعدها انها تظبط السكر. ممكن زي ما قلت لحضراتكم محلات كتير ما يحتاجوش ياخدوا انسولين، بس بالإديوكيشن، وانها طبعا لازم نعلمها تتابع السكر بتاعها زي ما اتفقنا. لا هو نقلل الكربوهيدرات it doesn't mean ان احنا نعمل very low carb او restricted carb، بس نقلل شويه especially نوعيه الكربوهيدرات. يعني الكربوهيدرات اللي جايه من الفروتس كويسه، لكن الكربوهيدرات اللي جايه من الحاجات المصنعه دي حاجات مش كويسه. تختار نوعيه العيش مثلا، بالنسبه لك تبعد عن العيش الابيض او الفينو، وتاخد الحاجات العيش البراون بريد واللي فيه رده، ده يبقى افضل. فهي الفكره مش بس كميه الكوانتيتي في الكربوهيدرات، هي الكواليتي ونوعيه الكربوهيدرات اللي هتستعمله. بس انا قصدي في الكربوهيدرات بتاع الصبح انهم يبقى عندهم عرضه البوست برانديال بتاع وجبه الفطار يبقى اعلى وجبه بالنسبه لها، فعلشان كده هنحاول ننصحها وجبه الفطار بلاش تزود الكربوهيدرات فيها لو هي بتعاني من ارتفاع السكر، خاصه بوست برانديال. يعني عندهم مشكلتهم مش بتبقى في الصايم، هو الصايم بيبقى بتاعي غالبا كويس. علشان كده حضراتكم هتلاحظوا اثناء الادجستمنت بتاع الانسولين دوزس نلاقي اكتر، احنا في عاده مثلا لو واحد على توتال انسولين زي تايب 1 بندي البيزل انسولين 50 to 60% والبرانديال الباقي. هتلاحظوا حضراتكم الريشيو دي تختلف في الحمل يبقى البيزل انسولين نيدز بتاعتها ثابته تقريبا، نادرا لما محتاج نعليها، وهتلاقي حضرتك بتعلي الايه البرانديال انسولين هو اللي عالي، لان مشكلته تبقى مينلي بوست برانديال مش الفاست بتاعه. تمام. طبعا الوزن، طبعا تخلي بالها من الوزن سواء قبل او بعد الحمل. لو اللايف ستايل يعني احنا بنعلمها ونقول لها هندي فرصه لنفسنا اسبوع 10 ايام، وهتعملي سكر صايم وبوست برانديال سواء بعد ساعه او ساعتين في التارجتس اللي اتفقنا عليها. هي تلاحظ نفسها لقت ارقام السكر الصايم او البوست برانديال بعيده عن التارجتس اللي احنا فيها، يبقى ده ساعتها خلاص شيز النيد انها تعمل كنترول عن طريق الانسولين. يعني مش هنجازف، لان طبعا في الحمل ما عنديش وقت كتير، انا كل ما هعرض البيبي الهايبرجليسيميا كل ده ما هيزود فرص الكومبليكيشنز، فبالتالي هدي نفسي فرصه 10 days 2 weeks at maximum، ارقام بعيده على طول هنشيت التريتمنت، مش هنستنى كتير يعني. شكرا لحضرتك، ميرسي حضرتك، ربنا يخلي حضرتك. في سؤال عند حضرتك؟
أنا الأستاذ الدكتور عبد الشافي، دكتوراه أنفوذ القصر العيني. بالنسبة للست البريجننت أو اللاكتيتنج وومن بصفة عامة أو البريجننت، حضرتك تنصحيهم ودايبيتك يعني تنصحيهم ممكن يصوموا صيام المسلمين؟ ده السؤال الأول. والسؤال الثاني، يتعشوا ولا ما يتعشوش؟ شكرا.
هجاوب السؤال التاني اللي هو السؤال الاسهل. شكرا لحضرتك. يتعشوا ولا ما يتعشوش؟ يتعشى بس لو هي بتاخد انسولين، لان غالبا انا لو بتكلم على بري اكزيستنج دايابيتس او واحده سكراتها عاليه بتاخد انسولين، هتتعشى هتحسب الجرعات بتاعتها بما يناسب الوجبه اللي هتاخدها بتتعشى. لو هي متعوده تتعشى هتاكل عشاء عادي، بس it depends على individualized. يعني في ناس مثلا ما بتحبش تتعشى بالليل، خلاص it's up to her، اوكي. واحده بتحب تتعشى عشاء تقيل، لا دي هنعلمها ان احنا هناخد عشاء مناسب وهنحسب الجرعه بتاعتنا حسب الوجبه اللي هتاكلها، وبرده نعلمها الكواليتي بتاعت الاكل اللي بتاكله. يعني ما تاخدش حاجات دسمه، حاجات عاليه، حاجات سكريات مصنعه، تختار، وده بغض النظر جرعه وجبه فطار او غداء او عشاء. السؤال الثاني لحضرتك الخاص بالرضاعه، تصوم الصيام يعني لو في رمضان وهي مرضعه تصوم ولا لا؟ قصدي حضرتك كده؟ يعني هي معاها رخصه كده ولا كده، سواء في دايبيتس او من غير دايبيتس، الحامل والمرضعه معاها رخصه انها تصوم او ما تصومش. فيعني دي هي معاها رخصه، وربنا يحب ان ايه تؤتى رخصه يعني. الحاجه الثانيه، هل في دينجر بقى لو هي صممت انها تصوم؟ هو لحد دلوقتي الايفيدنس مش قوي، احنا ما نقدرش نقول 100% it is safe او unsafe، فساعتها هيعتمد على stratification. يعني هل هي بس عشان الرضاعه، ولا she is a cardiac patient بيجي لها repeat attacks of hypo، بيجي لها hypoglycemic unawareness. دي كلها حاجات تدخل في الحسبه او في قرارنا انها تصوم ولا لا. لو عشان الرضاعه بس وهي تقدر تصوم وما عندهاش مشكله وسكرها مظبوط، لا ممكن نشجعها انها تصوم لو هي عايزه تصوم. شكرا لحضرتك.
Thank you for the speakers and the audience, and we are calling for the chairperson of next session,